right, let's hit it. We're going over chapter 15 with abnormal mobility. So let's hit it. Introduction. So mobility, as we know, is a critical part of maintaining independence and is an essential attribute of quality of life. Therefore, with impaired mobility, including disorders of gait, it's one of the earliest and most characteristic symptoms of a variety of neurological disorders. AKA, when you're in the gym, make sure you're doing a little mobility routine, not just like picking up and dropping some weights, because it's super, important. So continuing on. All right, so gait classification. There's been a number of classification schemes proposed, but there's a little consensus on the best framework for classifying gait disorders. Gait classification is designed to organize individuals into homogeneous groups, which then can be used to assist clinicians with clinical decision-making regarding therapeutic interventions to improve gait. One of these schemes was to classify disorders of gait based on neurological disorder itself, but ultimately, according to studies, there seemed to be significant heterogeneity, hopefully I said that right, among persons walking with an apparently homogeneous gait pattern. Researchers have also classified gait according to the primary pathophysiologic mechanism producing disordered gait. For example, Serena and Inverno identified 4 main mechanisms contributing to disordered gait in individuals with central nervous system pathologies, which include paresis, spasticity, loss of cell activity and motor output, and a non-neural component. Regardless of the type of classification system used, understanding the effects of the sensory motor and cognitive impairments on mobility function, as well as the types of patients likely to have these problems, is essential for examining and treating the patient with mobility problems. As you can see in the picture over here, where my mouse is so you guys can see it, obviously that's kind of the ICF model, and it kind of, classifies where gait would be in regards to the ICF model. The purpose of just classification is to organize individuals into homogeneous groups, and that's kind of what we just went over. Let's get to it. We're going to be breaking down those 4 major mechanisms. First off, starting with paresis. Boom. Paresis, or otherwise known as weakness, is a primary neuromuscular impairment affecting the number, type, and discharge frequency of motor neurons essential for force production during gait. Paresis has both a neural component and a non-neural component of force production. The neural component results from insufficient supraspinal recruitment of motor neurons in specific leg muscles. Non-neural contributions to weakness reflect secondary changes in muscle fibers themselves that affect the patient's ability to generate tension. So how does paresis affect the ability to walk independently? This depends on which muscles are weak, the extent of the weakness, and the capacity of other muscles to substitute for weak muscles in achieving the requirements of gait. We'll briefly highlight some of the select groups of lower extremity muscles on gait here right now. In regards to plantar flexors, there's a significant reduction in muscle activity in both plantar flexors and the tibialis anterior. A weak quadriceps will lead to difficulty controlling knee flexion during loading and min stands, with the primary compensation for this being hyperextension of the knee, as the forward movement of the body weight will serve as the knee extensor force instead. Weak hip flexors affect the swing phase of gait by not allowing sufficient momentum at the hip to indirectly flex the knee. Hip extensor weakness results from forward trunkling that threatens stability, and to compensate for this, patients will lean backward to bring the center of mass behind the hips. Weak hip abductors draw the pelvis on the side contralateral to weakness, aka Trendelenburg gait. Obviously, with weakness, there is a significant effect on gait speed. So overall, paresis affects the loss of control of movement through eccentric contractions and loss of generation of movement through concentric contractions. The degree to which weakness impacts gait may depend not just on the severity of impairment and affect the limbs, but the capacity of non-periodic muscles to compensate. Ooh, I struggled there. Alright, so next up we have spasticity, which happens to be the second major mechanism of a disordered gait that we're going to be over. You're almost done with me, y'all. You'll have Samantha here in a second. She'll go over the other 2, so it'll be great. Hope you're hanging in there. But spasticity is a frequent component of neurological disorders. Many researchers have looked at its effect on gait, and it's found to impact gait in 2 ways. Firstly, spasticity results in inappropriate activation of a muscle at a point during the gait cycle when it is being rapidly lengthened. In addition, spasticity alters the mechanical properties of a muscle during increased stiffness. And obviously, if you have increased stiffness, your body doesn't move as well, therefore altering your gait. So we'll highlight some of the effects of spasticity in certain key muscles. Moving on. We got spasticity in the plantar flexors, essentially. So spasticity in the ankle plantar flexors is a common problem following a neurological neurologic injury and is commonly seen in patients with a stroke, cerebral palsy, and following a traumatic brain injury. Plantar flexors contribute to pathologic gait patterns in stance and swing phases of gait. Plantar flexor spasticity will affect foot position at initial contact, thus having an impact on the stability component of gait. Spastic plantar flexors limit dorsiflexion, and this prevents heel strike at initial contact. Thus, initial contact is made with a flat foot that the ground reaction force vector is anterior to the knee, producing knee hyperextension. Plantar flexors also affect forward foot clearance during swing, resulting in toe drag, as you can see in the picture, with the ground reaction forces being anterior to the knee. So yeah, it's hyperextension of the knee, and then the toe drag because of foot clearance, because obviously we have super tight plantar flexors that are spastic. So yeah, our tibialis anterior needs to come in clutch for that, but it's probably weak at this point. So moving on, we have the quadriceps. So quadriceps spasticity results in excessive knee extension in stance phase of gait and can also lead to stiff knee gait during swing phase. Hamstring spasticity prevents the knee from fully extending, resulting in knee flexion at initial contact. From there, excessive knee flexion persists throughout the stance phase of gait, increasing the demand on the quadriceps muscles to prevent collapse of the limb. Hip adductor spasticity is similar to hip abductor paresis, as it results in contralateral drop in the pelvis during stance. And all spasticity contributes to disordered gait through the inappropriate action of a muscle during the portions of the gait cycle, which is lengthened, and through changes in stiffness resulting from alteration in the mechanical properties of the muscle itself. That was a mouthful, and I'm sorry again for my slurring of words. Spasticity and big, sophisticated words tend to be hard for little old me. So yeah, next up is Samantha. Little midway through snaps for her, so yeah, rock on.
Next, we're going to talk about loss of selective control and the emergence of abnormal synergies. An inability to selectively recruit muscles is a significant factor contributing to abnormal gait in patients with CNS pathology. This loss of independent control of selected muscle groups is often associated with abnormal coupling of muscles, resulting in abnormal synergies. These synergies manifest in gait as either total extension or total flexion patterns and can be seen as simultaneous activation of extensors during the stance phase or flexors during the swing phase. In an extension synergy, we have internal rotation, adduction, and extension of the hip, knee extension, and ankle extension and inversion. And in a flexion synergy, we have external rotation, abduction, and flexion of the hip, knee flexion, and ankle dorsiflexion and eversion. In both of these synergies, we can have a reduced stability and abnormal gait patterns. And an example of this is when you have a flexion synergy, the abnormal coupling between the hip and ankle flexors can result in a reduced stability to extend the knee while flexing the hip during terminal swing. Next, we have coordination problems, and these can result in impaired coupling among body segments and are a major factor contributing to impaired gait in patients with CNS pathology. This impaired coordination can manifest as non-stretch related muscle overactivity, impaired segmental or intersegmental coordination, as well as coactivation of agonist and antagonist muscles. Overactivity of muscles can be as problematic to the control of gait as the inability to recruit muscles for both progression and postural control. And this makes sense if you think about in normal gait, you've got that normal activity of muscles, and if you have an overactivity in any specific muscle, you could cause problems with the coordination of normal gait patterns. For impaired segmental coordination, it involves the inability to control the timing and scaling of muscle activity during gait. This is a common finding in gait disorders from pathologies in the cerebellum, like ataxic gait, and in the basal ganglia, like gait in Parkinson's. So specifically in Parkinson's, you can see the inability to control timing and scaling of muscle activity with the reduced speed and amplitude of leg movements, and also episodes of freezing. For impaired intersegmental coordination, you have the reduced ability to coordinate movements between body segments. So one of the examples of this is the effect of pathologies on arm swing during gait. So CNS pathologies can affect the interlimb coupling by disturbing the amplitude and timing of arm swing, and also disrupting the synchronization of arm-leg coordination. So basically, your arms, the timing of them are not moving right with each other and also with the legs, which causes coordination problems. And then coactivation of agonist and antagonist muscles also contributes to coordination problems since it causes deviation from normal muscle activity during gait. So during normal gait, there's a reciprocal recruitment pattern so that the coactivation of agonist and antagonist muscles is minimized. So if you have this coactivation, which you can see in people with stroke or kids with CP, you can see a loss in that selective recruitment of antagonist muscles, which would cause problems with coordination. Next, we have musculoskeletal impairments. These also impact gait and can be things like weakness, loss of range of motion and contractures, and changes in alignment. So for limited joint mobility, in general, decreased joint mobility during stance restricts forward motion of the body over the supporting foot, which can affect the progression of gait. And in swing, decreased joint mobility reduces foot clearance, affecting progression, and appropriate foot placement for weight acceptance, which affects stability. Also, limited range of motion limits a patient's ability to modify movement strategies. So if you have someone who has limited ankle and knee flexion, they might not be able to increase the flexion of that limb to step over an obstacle. And then we have contractures. So an ankle plantar flexion contracture can limit the advancement of the tibia over the stationary foot during stance because it doesn't allow for that 5 degrees of dorsiflexion that you need for progression. And in a hip flexion contracture, you can have inadequate hip extension, which can cause problems with stability and progression during gait. So if the hip can't extend to neutral during mid-stance, the trunk will flex forward, bringing the center of mass anterior to the hip joint. And then in terminal stance, this lack of hip extension causes anterior pelvic tilt and an inability to move the thigh posterior to the hip, which causes a shortened step length and reduced forward progression. Last, we have impaired adaptation of gait. Inability to adapt gait to environmental challenges like inclines, curbs, and obstacles significantly limits participation in mobility-based activities. This diminished adaptation results from both impaired reactive balance and impaired proactive balance. Reactive balance strategies integrated into the gait cycle are necessary for the recovery of stability following an unexpected perturbation, so this could be like a trip or a slip. So if you have problems with reactive balance strategies, then you're going to have problems with stability. An example of this was in the book. There was a study that found that impaired stepping response among patients receiving inpatient rehab for stroke was strongly associated with increased rates of falls. So because these people did not have good stepping responses, which is a reactive balance strategy, they were more likely to have instability, causing an increased rate of falls. For proactive balance control, complex walking tasks like stepping over or around obstacles, changing directions, or accelerating or decelerating to avoid collisions all require proactive balance control. If you don't have this proactive balance control, it can cause problems with obstacle crossing, problems turning while walking, and difficulty adapting to terrain changes. And that's all for this section.